Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 338 of our pharmacotherapy series, which majors in drug interactions. My first question to you reads, NOM is a 68-year-old obese Hispanic female who underwent a total knee replacement at a local teaching hospital. The medical team plans to start NOM on Warfarin therapy for venous thromboembolism prophylaxis with an international normalized ratio, abbreviated as INR, target range of 1.8 to 2.3 for a total duration of 3 weeks. The first dose will be administered in the evening on the day of surgery. Her medical history includes epilepsy for the past 10 years, controlled with phenytoin, hypercholesterolemia for the past 15 years, for which she takes pravastatin, and hypertension for the past 20 years, for which she takes lisinopril. Her social history includes a 1-pack-year history of smoking. She does not drink alcohol. She takes acetaminophen for headaches and has taken other over-the-counter medicines as needed, but doesn't recall the names of the products. Her renal and hepatic functions are within normal range. Describe NOM's risk factors for drug interactions with the addition of warfarin post-surgery. NOM has multiple factors, including patient-specific and drug-specific ones, that increase her risk for drug interactions. Her patient risk factors include obesity, age, gender, and smoking history. The patient risk factors include 1. Female gender. 2. Metabolic factors, e.g. obesity. She has increased distribution of lipophilic drugs, e.g. phenytoin, comorbidities, e.g. hypertension, and hypercholesterolemia. 3. Age. She is 66 years old, and therefore has altered pharmacokinetics and pharmacodynamics. 4. Smoking history, which induces the cytochrome, CYP, P450 system. With regard to drug-specific factors, NOM has been taking phenytoin, a drug with a narrow therapeutic index, for the past 10 years. She will be receiving warfarin, another agent with a narrow therapeutic index. Both medications are metabolized via cytochrome P450 system. In addition, NOM is at increased risk of additional drug interactions due to polypharmacy, because she has chronic disease comorbidities, i.e., seizure disorder, hypertension, and hypercholesterolemia. Next we will consider drug risk factors. 1. Warfarin has a narrow therapeutic index. It is highly protein-bound to albumin. It has a small volume of distribution, and is metabolized by the cytochrome P450 system. 2. Phenytoin has a narrow therapeutic index. It is highly protein-bound to albumin. It is metabolized by CYP2C9 and CYP2C19 isoforms, and susceptible to drugs that inhibit hepatic microsomal enzymes. 3. Regarding pravastatin, whereas pravastatin does not appear to interact with warfarin, other agents in this class, i.e., atorvastatin, fluvastatin, rosuvastatin and simvastatin, have been suspected or are known to alter the INR in patients who receive warfarin. 4. Regarding lisinopril, there is a concern when administered concomitantly with diuretics or potassium supplementation. Other risk factors include polypharmacy. Prior to admission, she is already on 3 prescription drugs and also takes OTC products. She is a poor historian. And the next question reads, describe the interaction of warfarin and phenytoin based on protein binding. Following administration and absorption, drugs are distributed throughout the body. While some drugs have near-complete dissolution in the plasma, drugs such as warfarin and phenytoin are highly bound to protein, primarily to albumin, with the same affinity binding sites. Drugs that are highly protein-bound, that is greater than 90%, those with a narrow therapeutic index, and those with a small volume of distribution are more likely to result in significant drug interactions. Warfarin can be displaced from protein binding sites by drugs such as phenytoin. Although this displacement occurs quickly with rapid changes in serum warfarin levels, typically this interaction is not clinically significant. Warfarin that is displaced from protein binding sites is readily available for elimination by hepatic metabolism, resulting in increased clearance without a significant change in the free drug concentration. Because warfarin's anticoagulant action takes several days due to the long half-lives of some of the vitamin K-dependent clotting factors, warfarin equilibrium is re-established before a new steady state can be reached for these clotting factors. We will now progress to metabolism. Pharmacokinetic interactions that involve changes in metabolism are a common cause of clinically significant drug interactions. Drug metabolism is divided into 2 general categories: Phase 1 and Phase 2 reactions. Phase 1 reactions involve intramolecular changes including oxidation, reduction, and hydrolysis, which increases the polar nature of the drug, generally making it less toxic. Phase 2 reactions generally involve combining a Phase 1 product with an endogenous substance resulting in glucuronidation, sulfation, acetylation, and methylation, and primarily results in termination of biologic activity of the drug. The main enzymes that are responsible for drug metabolizing systems in Phase 1 reactions are the cytochrome, CYP, 450 enzymes, which play a key role in many therapeutically important drug interactions. Drugs that are metabolized by the same CYP 450 enzyme family, when administered concurrently, may interact with each other as a result of induction or inhibition. Of the human CYP 450 enzyme family, the 6 isozymes CYP1A2, CYP2C9, CYP2C19, CYP2D6, CYP3A4, and CYP3A5 contribute to the metabolism of a vast majority of drugs compared with other enzymes. Examples of drug that induce enzymes are rifampin, phenytoin, carbamazepine, St. John's wort, and nevirapine. Enzyme inducers cause an increase in the synthesis of the enzyme or enzymes responsible for metabolism of the substrate drug. The mechanisms of induction are complex, involving presystemic metabolism via induction of hepatic and/or intestinal drug metabolizing enzymes, subsequently reducing serum concentrations with a loss of pharmacologic activity of the drug. In some cases, Induction will increase the formation of metabolites that are pharmacologically or toxicologically active. There are many drugs that are inhibitors of CYP450, including some drugs within these classes. Statins, macrolide antibiotics, antifungal azoles, fluoroquinolones, and HIV protease inhibitors. Inhibition of drug metabolism slows down the rate of drug metabolism, resulting in an increase in the amount of drug in the body and potential toxicity. Grapefruit juice is an inhibitor of CYP3A4 and has been known to increase the bioavailability and reduce the clearance of many drugs including HMG coenzyme A reductase inhibitors, that is the statins, calcium antagonists, HIV protease inhibitors, and immunosuppressant agents. Inhibition can be described as reversible or irreversible, with the reversible ones being a more common process. There are three mechanisms of reversible inhibition: competitive inhibition, competition between the inhibitor and the substrate for the enzyme's active site; non-competitive inhibition, binding of the inhibitor to a separate site on the enzyme, rendering the enzyme complex non-functional; or uncompetitive inhibition, binding of the inhibitor only to the substrate enzyme complex, rendering it ineffective. Irreversible inhibition occurs when the perpetrator drug forms a reactive intermediate with the enzyme that leads to a permanent inhibition of the enzyme. Irreversible drug interactions tend to be more profound than those caused by reversible mechanisms. Examples of drugs that are known to cause irreversible inhibition include macrolide antibiotics, erythromycin, clarithromycin, paroxetine, and diltiazem. The medical team starts NOM on warfarin therapy post-surgery for thromboembolism prophylaxis. The medical intern asks you to explain the mechanisms of drug interactions to consider with the use of warfarin and phenytoin because NOM has been on phenytoin for the past 10 years and her seizure disorder has been controlled on it. There are two potential mechanisms for a warfarin, a drug, phenytoin, a drug, interaction. In early therapy, there could be a displacement of warfarin from protein binding sites by phenytoin, as described in the previous case question, and a possible enhancement of the anticoagulant effect and risk for bleeding. This is primarily a concern in patients with hepatic impairment. With prolonged therapy, there could be a phenytoin-induced CYP enzyme induction, thereby enhancing warfarin metabolism resulting in a decreased warfarin effect. INR monitoring on postoperative days 1 through 5 will provide information on the impact of the drug-drug interaction, and incorporation of a warfarin initiation guideline or algorithm will help adjust dosing until a stable regimen is established. After the initial period, weekly INR monitoring will provide information on enzyme induction and further adjustment of warfarin doses. Warfarin is rapidly and completely absorbed after oral administration, with the proximal duodenum appearing to be the most likely location of absorption. Case reports of warfarin malabsorption, whether acquired, related to surgery, or inflammatory conditions, are rare. The rate and extent of phenytoin absorption varies considerably among oral dosage forms. Phenytoin suspension is poorly absorbed when administered via feeding tube with continuous enteral feedings. The time to reach maximum plasma levels increases with increasing dose. This is a reflection of low phenytoin solubility and capacity-limited metabolism. Therefore, a small change in the dosage form or bioavailability, coupled with limited metabolism, can produce a large change in plasma drug concentration. Gastrointestinal surgery and gastrointestinal inflammatory conditions, e.g. Crohn's disease, ulcerative colitis, scleroderma, etc., can change the anatomy of the gastrointestinal tract. Alterations to surface area, gastric emptying time, gastric pH, and inflammation of the intestinal lining may lead to abnormal plasma concentrations. NOM's gastrointestinal function is still preserved after orthopedic surgery. Warfarin administration and absorption is unlikely to be impacted. She should continue on the same phenytoin dose and formulation that she has been taking at home with appropriate monitoring. Pharmacokinetic interactions influencing the metabolism of warfarin and clinically significant interactions are likely with warfarin use when its metabolism is induced or inhibited. Warfarin is a racemic mixture of R and S enantiomers. Interactions involving agents known to influence the hepatic microsomal enzyme systems responsible for the metabolism of the more potent S enantiomer, CYP2C9, are more significant than those that influence the enzymes that metabolize R enantiomer, CYP1A2, and CYP3A4. Phenytoin is also predominantly metabolized via the CYP2C9 enzyme and has been reported to interact with warfarin in a biphasic manner. Genetic polymorphism also is a significant factor affecting warfarin dosing and response. Nucleotide polymorphisms have been identified that influence warfarin metabolism and sensitivity, including variants of CYP2C9 and variants in vitamin K epoxide reductase complex, abbreviated as VKORC1. Let's now consider excretion or elimination. Drugs are excreted and eliminated mainly via the kidneys, that is glomerular filtration, tubular reabsorption, and active tubular secretion. Other important, though less common, routes are via biliary secretion, plasma esterases, and other minor pathways. Drug interactions may occur during the elimination of drugs and their metabolites by the kidney as a result of competition at the level of active tubular secretion, interference with tubular transport, or during tubular reabsorption. Urinary alkalinization and acidification by some drugs can affect the excretion of other drugs, changing their elimination rate. For example, the use of probenecid, a potent inhibitor of the anionic pathway of renal tubular secretion, increases the serum concentration of penicillins, which can be used for therapeutic purposes. And now we will proceed to pharmacodynamics. Pharmacodynamic interactions occur when the response of one drug is modified by the presence of another one without alterations in pharmacokinetics. These types of interactions may be predicted if the pharmacologic effects of a drug are known, and the patient response may be additive or antagonistic. For example, there may be an interaction in which one drug, an ACE inhibitor, and another drug, a thiazide diuretic, each act by a different mechanism of action to lower blood pressure, producing an exaggerated hypotensive effect. The next question reads, the intern asks you to explain the pharmacodynamic interactions that are clinically relevant to warfarin. Pharmacodynamic interactions with warfarin are those that alter the physiology of hemostasis, particularly interactions that influence the synthesis or degradation of clotting factors, or that increase the risk of bleeding through inhibition of platelet aggregation. In patients receiving warfarin, the addition of any drugs that increase or decrease clotting factor synthesis, enhance or reduce clotting factor catabolism, or that impair vitamin K production by normal flora will increase the risk of drug interactions. The next question reads, the medical intern on the team also plans to prescribe a combination analgesic, that is oxycodone co-formulated with acetaminophen, in place of intravenous morphine for the pain management. In a telephone conversation, NOM expressed to a friend that she felt depressed. As a result, Her friend brought her a bottle of St. John's wort. As the pharmacist on the multidisciplinary team, your role is to assess therapy and make recommendations as needed. Provide appropriate recommendations regarding NOM's therapy, including the use of St. John's wort. Although acetaminophen is a commonly used non-prescription analgesic and antipyretic medication for mild to moderate pain and fever, its presence is often unrecognized in combination products containing opioids prescribed for moderate to severe pain. Several studies have identified acetaminophen as a culprit drug in potentiating the effects of warfarin. Patients who take 4 325 mg acetaminophen tablets per day for longer than a week were more likely to have an INR above 6 than those who did not take acetaminophen. There is no evidence for a pharmacokinetic interaction between acetaminophen and warfarin. However, acetaminophen is metabolized by CYP2E1, producing the metabolite N-acetyl P-benzoquinone, abbreviated as NAPQ1. NAPQ1 oxidizes vitamin K hydroquinone, abbreviated as KH2, the active form of vitamin K, and directly inhibits vitamin K-dependent carboxylation. There may be other oxidative changes, producing enzymatic disruption, that impact vitamin K synthesis and activity. The end result is an exaggerated response to warfarin and an increased INR. Therefore, if NOM is to be placed on oxycodone co-formulated with acetaminophen therapy, her INR should be monitored more frequently and her dose adjusted accordingly. This is important particularly if she requires higher sustained doses of warfarin. Dietary supplements, including herbal medicinals, amino acids, and other non-prescription products, are not tested before marketing for interactions with other medications, including warfarin. Little is known about their interactive properties, other than published case reports of varying quality. In addition, dietary supplements are not required to meet U.S. Pharmacopeia standards for tablet content uniformity. St. John's wort, a herb whose yellow flowers and leaves are used to make herbal supplements, has been used for treatment of depression. It has also been shown to lower patient INR values and potentially decrease warfarin's effectiveness. Although this interaction is probably due to the induction of CYP2C9, the degree of induction is unpredictable due to variable quality and quantity of the herbal constituent in the preparations. Similarly, St. John's wort has been suspected of reducing phenytoin plasma concentrations through induction of CYP3A4. The addition of St. John's wort to NOM's current drug regimen would not be advisable because it would increase her risk for drug interactions. The implications for initiating St. John's wort in NOM would require measurement of phenytoin and more frequent INR testing to ensure a new steady state for each agent has been reached. At this point, it is important to assess NOM's depression and to evaluate therapeutic options that would provide the least risk of drug interactions, as well as psychosocial treatment. The next question reads, Pravastatin, the medication that NOM was taking prior to admission, is not available on the hospital's formulary list. Therefore, the medical intern prescribes the formulary preferred agent rosuvastatin post-surgery. He receives an electronic health record drug interaction alert regarding the statin and warfarin and asks you how this should be managed. Rosuvastatin is not metabolized extensively by the CYP450 system, that is approximately 10% with CYP2C9 and CYP2C19 being the primary isoenzymes involved. However, The combination of rosuvastatin and warfarin has resulted in an increase in the INR and hence increasing risk of bleeding. Each of the statin agents is metabolized by different CYP isoenzymes and to different degrees. The goal of lipid management is to prescribe an agent with the least side effects and at the lowest effective dose. If a patient, such as NOM, requires a drug that interacts with statin metabolism, via CYP, switching to a statin that has a more favorable elimination profile may be the best option. In this instance, pravastatin, which has limited CYP metabolism and is primarily excreted unchanged in the urine, may be the optimal choice. Otherwise, rosuvastatin may be used, but more frequent monitoring of the INR is recommended until a stable INR has been reached. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 339.